For those watching either now or later, hi everybody, I am Dr. Prabakar. I'm a board certified OBGYN practicing in the Bay Area in California, and I have a very special guest today, Dr. Megan Melo.
Melo
Am I saying
Yellow.
your last name right? Melo. Melo. Okay, great. So I'm going to have her introduce herself, and then we're going to get into our topic.
Thank you so much. So I'm Dr. Megan Melo. I'm board certified in family and obesity medicine, and I practice in Seattle, Washington.
All right. So great. So we're going to talk about obesity medications, some of the newer medications out there in the market now, and who should be on it, who should not be on it. As a gynecologist, so many patients talk to me about these medications, especially around menopause. So I want to hear all about that. But tell us first a little bit kind of about your practice right now. You said you're board certified in obesity medicine. What exactly does that mean? Who do you, what kinds of patients do you see?
Yeah.
So tell us a little bit about your practice.
I'm currently in private practice, and I work out of a small physician-owned practice in Seattle, Washington as an independent contractor. So I'm really a community-based, primary care-based family and obesity medicine specialist. So I have primary care patients for whom, I am just their primary care physician, but I also specialize in obesity medicine. And so whether they are my primary care patients or patients who are seeking consult for obesity medicine treatment, I provide that in an outpatient, kind of community setting, as opposed to a lot of places where the obesity medicine has, kind of come out of academic medicine. And so for a long time, that was really where you found obesity medicine trained physicians. And that is starting to change as more people become interested. But it's what's called a secondary certification. So you're OBGYN trained, I'm family medicine trained, right? Those are our primary residency certifications, and that's our primary role. But there are these secondary medication or certifications such as obesity medicine, lifestyle medicine, your minimally invasive surgery, some things that we do afterwards to further specialize and hone certain skills.
Awesome. Yes. So, and also the setting that you're working in makes it a little more accessible to patients as well, rather than having to find a academic center. So let's talk about who these medications are for. I think there's a lot of confusion about that. I know a few months ago, Wegovy was like, oh, the wonder drug, and everybody was asking for it. And, you could just kind of circumvent and bypass all the hard work you had to do. And, so it seemed like the quick fix. So tell us a little bit more about who should be using
I think it's an interesting time because for such a long time, what we've had in the marketplace is diet drugs, right? Diet drugs that, were intended, sometimes they were prescription medications, sometimes they were other supplements that people would use. But the idea was a short-term medication really to help with weight loss. Might overcome hunger signals, for example. So if we decrease hunger, right, it's easier to eat less food and have success. But what the science really shows us is that there are metabolic changes going on, some that have to do with insulin resistance and some that are just metabolism. When we go to a higher body weight and then we lose weight, our body has a harder time staying at that lower body weight. The calories required to maintain that lower body weight are going to be less than someone who had never gained weight in the first place. So for example, if somebody always weighed 180 pounds and they needed 1,800 calories to maintain 180 pounds, that's different from somebody who gained weight to 220 pounds and then lost to 180. That person's calorie requirements probably go down to 1,700. And those are just kind of round numbers, but and every time the weight goes back up and then comes back down, that calorie requirement to stay at the lower body weight drops further. And meanwhile, there's often some hormone changes that are going on, hormones ghrelin and leptin that have to do with hunger and satiety, that are increasing hunger and decreasing the sensation of fullness after we eat. So people will tell you their lived experience is that it's harder and harder each time that they do that. And that's very true. So metabolically speaking, their calorie requirement has gone down, and they're more hungry and less satisfied with the food that they eat. So it's a real struggle. These medications have been a major change. You know, when we're talking about medications like Wegovy or semaglutide, Ozempic is the diabetes version of those medications. But they're really quite powerful in reducing hunger, improving fullness. They're also working a little bit on insulin resistance, and a lot of people will tell you that they think about food less, they have fewer cravings for food, so it really is a much more comprehensive approach than a lot of the things that we've had out there. Before Wegovy really launched on the market, we do have some successful medications that have really been underutilized for a variety of reasons. But still kind of what's commonly known is this idea of diet drugs, this idea of temporary medication that we might use to lose the weight. But as we were just talking about, it doesn't really work very well to do that. So these medications and others are really a long-term strategy that need to be kept going. Yeah, so and that's a hard one for people to kind of wrap their brains around, because we want to think, I'll just lose the weight, I'll be fine, and then things will be fine. And you know, it really doesn't work that way. They're common experience people have. They'll say, well, I lost a lot of weight on keto, right? I did keto diet or ketogenic diet for 6 months. I lost a lot of weight, and then I stopped, and then I gained the weight back, right? Anything that we do to lose the weight, we really have to keep doing, and that includes medication. It includes when people have bariatric surgery, right? We need to maintain those changes in order to sustain a weight loss.
Yeah. I mean, even the concept of the fact that to maintain a lower body weight after you've lost that weight, you can only eat, fewer calories. That itself is like something that I didn't even think about. And then
the more we yo-yo, the worse it gets.
Gaining and losing.
Yeah.
Gaining and losing, it's harder and harder. Which I think for a lot of my patients who are in menopause, they've already tried a lot of these diets and different things and gone up and down, and then they really feel like it's really hard at this stage of life. So before any of these medications, are prescribed, do you still have to see that patients have tried, a good diet and exercise? I know, for example, before they would do gastric bypass surgery, you have to show that, like, okay, you've done all these things and it's all failed. So what kind of process do you go through before you decide?
Great question. And I think it really depends on where people are starting. The insurance status of these medications is quite different from also most of the other medications we have. It's much more akin to the way fertility is covered as a separate package that employers can choose to add on to their health insurance. So anti-obesity medication and other anti-obesity treatments like bariatric surgery are not required to be covered by your insurance. And that's why we have such a state where a lot of people don't have coverage for these medications. A lot of people don't have coverage for bariatric surgery. In bariatric surgery, yes, they do often require at least 6 months of lifestyle changes in order for people to start on these to have surgery. And there's several different reasons why that's true. That's not always a requirement with these medications when employers choose to cover them. That being said, yes, I consider that an important part. Although some of these medications can be effective when people aren't making any changes, when we're really thinking about long-term success, long-term health, I think these medications need to be used alongside those changes, right? So it will change the way that you eat. It will, change your interaction with food. It's not going to change your physical activity, but because these medications are so effective for weight loss, it's really important that people are exercising and building muscle strength as they are losing weight to avoid losing a lot of muscle along with body fat. And so it's really important to consider all of those parts and to work together, but it's not necessarily a requirement that somebody has to have proven that they've made those changes. A lot of the patients who come to me, like the patients who sought care from you, have been doing things off and on for years, right? They've been up, they've been down, they've been on diets where they've successfully lost weight, and oftentimes they've regained, when they have stopped making that. And a lot of people will tell you they have sort of what I call diet trauma, right? Where they've been in these places where their eating is very restricted, they lost the weight, but they felt terrible. They felt like they were always hungry, they were always thinking about food, and that's very real for people, and it takes up a lot of brain energy, to be honest.
Yeah. Yeah. Okay. So it sounds like it all kind of goes together. The eating well, the exercising, building the muscle, and taking one of these medications. And the other important point is that it's not just take it for a month and then stop. It's more of a long-term kind of maintenance medication as well, which I don't think a lot of patients, realize, because if you stop, then you lose all those signals that were suppressing hunger, right? Okay. Now, are there any long-term, side effects of taking these medications?
Long-term side effects, not really. There are side effects with these medications, though. They do cause a lot of gut side effects, so they can include constipation, nausea, diarrhea. At the extreme end, sometimes people will have vomiting with these medications, and if that's ongoing and it's not getting better, they are not going to continue on that medication. We're not using it to be unsafe. We do see slight increased risks for things like gallstones, kidney stones, pancreatitis. Those are all pretty clear possible risk factors when using these medications, although that can also happen when people are losing weight with a highly effective method, including bariatric surgery, including very low calorie diets of 800 or less. We will see increased risk with all of those things. So when we're starting these medications, we have a clear discussion. You may feel nauseated when you're starting this medication. You may notice that you have some constipation. Those things will usually improve after you've been on them for a while. You may have more of that as we adjust the doses up. But if you're having any severe abdominal pain, if you're having, fevers, chills, vomit, like all of those things are not expected. They're not okay. We need to evaluate that more. So there's kind of those side effects. But then when we look at sort of long-term outcomes, right, we do see successful weight loss with these medications, and we do see additional benefits. So originally these medications were designed to help treat diabetes, and they do successfully help to reduce blood sugar levels, reduce insulin resistance, and really help diabetes. They are not a medication that drops our blood sugars too low either, such as insulin will do. So there's some great outcomes that way. Recent trials have also been showing us that we have reduced risk for cardiovascular disease, and people using these medications who have obesity or overweight with some other health concerns, but people who don't have diabetes. And that's a pretty major finding. It's helpful when we can reduce the risk for heart disease in diabetes, but to reduce the risk for heart disease outside of diabetes is a pretty remarkable finding.
Yeah, I just read that headline yesterday, and I thought, oh, perfect. I'm going to be talking about this tomorrow. So that's really good. That's a really good finding, and that's promising for those with obesity. We know that does increase your cardiovascular risk. So if we can minimize that through this medication, then that's good. Now, are there specific age ranges that medication is good for, like, the obese college student versus somebody in menopause, or somebody even later on in life, 70, who has knee problems and is like desperately trying to lose weight?
That's a great question. The different medications that are out there are approved for people as young as 12. And so we do have you know, relatively older children who are being treated effectively and safely with these medications. When I think about treating younger people, such as, you know, the child of that age or somebody in college, you know, we're thinking much more about the long-term impact of these medications. Although they appear to be very safe, to some extent, we're committing somebody to a really long time of therapy. And, you know, again, because of the status that we're in with current insurance coverage, which I do hope will change, you know, if somebody doesn't have insurance coverage for these medications, it's quite expensive. So I think we have to really be mindful of what we're doing. We don't yet have studies that show if we lose weight with these medications successfully and we reach maintenance, can we effectively transition somebody to something else, like a different pill, for example, some of the more effective anti-obesity pill medications that are out there in the market. So there's some work to be done around that. But in terms of older adults, you know, we certainly use these medications in older adults who have diabetes. And so really the weight shouldn't be any different so long as we consider them safe, you know, for that person's health.
Okay. Okay, great, great. Now, Ozempic is one of the common, you know, medications out there, and the name that sticks with me, right? Yes. What are some of the other? I think, is there just one more?
There's
Or what
a
are some of the
number
other
of medications
names
that came before Ozempic, and several of them have weight loss versions. However, they were not as effective as what we currently have. So liraglutide is one, exenatide. There were a few, and I think the brand names for those are Byetta and Saxenda. I didn't even use those ones.
Right.
But we've got semaglutide, which is Ozempic for people with diabetes and Wegovy for people who are treating obesity. And just last week, we found out that the weight loss version of Mounjaro, the generic name for that is tirzepatide, is coming out later this year, and that brand name will be Zepbound, which is an interesting name. I always joke, I wanted to be the person who named the housing developments, you know, but now I want to be the person who names the drugs because that just sounds fun, Zepbound. But that is another very powerful medication that might be even slightly more efficacious than Wegovy semaglutide. That medication works on two different hormone pathways, and so it may be more effective for weight loss and likely with very similar benefits in terms of cardiovascular disease and other important outcomes. So we'll have more competition on the market, which hopefully will help to expand access and put pressure on insurance companies and Congress to change the laws so that we get more coverage for these medications.
Absolutely. And now, just to be clear, these
Correct.
are all injections,
There is
right?
a version of semaglutide that is available in pill form for diabetes. Rybelsia is the brand name for that one. It may be somewhat effective in terms of weight loss, but no one is really using it for that at this time that I'm aware of, at least not in a widespread fashion. There are several other medications that are like in the pipeline, as it were, you know, being developed, and I think we'll see more of these medications coming out in the next several years. And again, I hope that helps to expand access. We don't like to think about paying for expensive medications like this, but when we really think, if this is reducing diabetes, if this is reducing heart disease, we are saving probably billions of dollars that we currently spend treating those conditions. I think the long-term impacts are potentially quite huge here. And I think that's how we have to think about it, rather than just focus on kind of the upfront costs, which of course is very real for people.
Absolutely. Yeah, especially if insurance does not cover it. That's a lot. It runs in the hundreds. And how often do you have to take this shot, inject yourself?
Two medications, so both semaglutide, which is Wegovy, and tirzepatide, which is Zepbound now, are once weekly medications. And so usually people will pick the day of the week that works best for them, and once a week they'll give themselves injections. They're usually started with both of these medications at a lower dose, and that's gradually increased. the manufacturers for these medications, see the best outcomes when people reach the highest doses. However, practically speaking, people sometimes are quite successful on lower doses of these medications, which is generally a principle that we use all the time in medicine. There may be an effective dose for somebody at a lower dose, and that's going to have less side effects. So that's going to be variable. I have some people who, are taking these medications and they very easily go up to the maximum dose. I have others who don't go up to the highest dose because of side effects or because they're getting good effect at a lower dose.
Great, great. And now, is there a population of patients who absolutely cannot use these medications? Like if you have this particular health condition, you can.
Yeah, quite rare, but there's a few people who we consider off limits for these medications, and that's people with a family history or personal history of medullary thyroid cancer, which is about 1 to 2% of all thyroid cancers. It's quite rare. It's a genetic cancer, unlike most of the common thyroid cancers out there, which are usually papillary. So people with that and people with a family history of something called multiple endocrine neoplasia, which other physicians will recognize is a board's question for many of us.
I was just going to say that. Right? Like, I think
also a very rare genetic cancer syndrome. In mice and rats who, these medications have been studied in, mice and rats have GLP-1 receptors on their thyroid glands and some of their other endocrine tissues. Humans do not have those receptors on their thyroid glands, but there's some concern because we saw increased rates of medullary thyroid cancer in mice and rats. And therefore, people with a family history who are genetically at higher risk, we do not use these medications. That is a very small number of people. Most people, we've never heard of those particular cancer syndromes. They're not known in our families. So that's a small kind of absolute. We say no on that. Those cancers are going to be studied and monitored with these medications. Do we see increased rates of this in humans, even though we don't have those receptors on our thyroids? But we'll see more with the data.
Oh, great. So I learned so much from this, our chat. So I wanted to recap some of the key ideas that I want people to walk away with, whether you're listening to us now or at some point later as a replay. But essentially these, we're talking about medications like Ozempic and Wegovy that are used for weight loss, and we've seen a really increased amount of usage in the last year in the United States. These medications are safe, they are long-term, so you actually have to keep using them to see the effect of weight loss. You can't just stop them after a month or two. So these are, you're kind of committing yourself more for a long-term use, and it's better, of course, with a good balanced diet as well as exercise, including weight-bearing exercise to keep up your muscle mass. They are approved from 12 years of age. Some of them, some are approved for patients with diabetes and others for obesity without diabetes. And it's a weekly injection and very few major side effects, but you can definitely have things like nausea, diarrhea, vomiting, as your body gets used to it. Most of those.
Yeah. And I'll say too, because I think it is important, as where we are right now, Wegovy has been in pretty significant shortage really since the summer of this year. And so the manufacturers are really emphasizing the higher doses right now in terms of production to make sure that people who are on this medicine already don't get pulled off of the medication because there's a shortage. Right now, it's quite difficult for people to find the lower doses. That has been true as well of the diabetes medication Mounjaro and Ozempic. And we expect, of course, that at some point these shortages will improve, but just like we've seen shortages with other kinds of medications, that is limiting people's ability to start on these medications. So it's not simply a question of, is this safe? Is this a good strategy for me? It's also, can I get medication right now? As well as the, can I afford it if it's not covered? So there's a lot of issues with it. But that may be why some people are, going to their doctors and they say, I want a prescription. Maybe you've decided, yes, this looks like an appropriate medication, but then we're running into, we can't actually find any doses anywhere because everybody wants it.
Yeah, which is something we're facing with a lot of medications these days. Huge shortage, both in the hospital and as outpatient. The struggle is real with that. So yes. So if you are watching and you are considering taking one of these, injections for weight loss, find an obesity trained physician, somebody certified in obesity medicine, because there's a lot of nuances, lots of ins and outs with this, and so that would be really important to find. And tell our viewers, Dr. Melo, where they can find you and
so for my medical practice, I'm at www.phinneypcw.com, and it's Phinney, Phinney. My clinic is Phinney Primary Care and Wellness in Seattle, Washington. And so people can find out information there, and I've got links to my YouTube channel where I talk about some of the obesity medication issues, so people can learn more of that.
Great. Well, thank you so much for your time today. This was really awesome. I know I learned a lot, and I'm sure those who are watching now or later will definitely learn a lot. Thank you for being generous with this information, and thank you to those who watched. And have a wonderful rest of your afternoon. All right. Bye. Bye, everyone.